see if I can get this right. All right, I think we might be live. What do you think? You think we're live? I can't tell, but hello everyone. I'm Dr. Sandy Rizaldi, and I have with me Dr. Jessica, the lovely Dr. Jessica. We are going to do a short webinar today, and we're going to talk a little bit about workplace bullying. So, and reporting, underreporting, and why it's so important to report. So let me go ahead. I'm going to bring this up. Let's see if we can get.
Not just the workplace, it happens everywhere.
Happens everywhere. Happens in school. It happens literally. Let's see. Huh?
Happens in the public.
Yeah. Yep. And then you know where it all starts at? It starts all the way from grade school. And why does it start all the way from grade school?
Can anyone tell me? I think it's communication whiffs personally and genetics, but
it's always about genetics. Okay. So, all right, guys. So I have my phone up here so I could see who's going to be on with us today. And so if you have any questions or anything like that, we wanted to keep it short and small, like not too overboard, because, you know, we kind of go overboard with our webinars, but we go a little over an hour usually. And it's just because we have so much to talk about. But today I wanted to have a conversation with Dr. Jessica about underreporting. So I am, just to back up a little bit, I'm the founder and CEO of Nurses Against Violence Unite. We are a nonprofit organization that has been around since October of 2017, and we're rocking and rolling. It's going to get even more fun, and we're going to offer opportunities for nurses as well as also for anybody that's looking for an opportunity to help the healthcare workers. We are expanding. We are going to be more of a professional organization, even more so than we already are. And it's going to be even more exciting. And I want to introduce you, Dr. Jessica Whalen. She is the Vice President of Nurses Against Violence Unite. And we have some other folks that are not joining us tonight because I wanted to keep it kind of short and get to the point. We're going to be talking again about underreporting and workplace bullying and violence. It's rampant. We have COVID. We have patients on nurse violence. We have nurse on nurse violence, nurse on CNA violence. We have what other violence? Doctor on nurse violence, administration on nurse, and all nursing staff. We have university, we have professors against students, and we have students against professors. We have everybody at each other's throat. And we wanted to talk a little bit about workplace violence and bullying. And let's talk a little bit about some of the things that I found when I was doing some of my DMP project. And it's pretty interesting of what of the things that I could find. Let me see if I can get my screen up here. So what do we know about workplace violence? We know it really, when you are on the receiving end, it's terrible. It's the worst thing ever. And it is, and it feels like you're all alone when nobody is trying to, nobody's sticking up for you. And I don't know why I just did that. Nobody's sticking up for you and you feel like you're all alone. And people make you feel that way. And is it fair? No, it's not fair, because you are a perfectly capable person to be able to take on your work assignments and stuff like that. So let's go ahead and share my screen. So this is something that's a little old. It's very short, but I wanted to kind of talk a little bit about it. So hopefully everybody could see my screen. Workplace violence. So patient on nurse violence, let's have this conversation, because it's not just patient on nurse violence, but let's find out exactly what is happening and why we feel like we're left out there with our butts hanging out in the wind and nobody there to save us, right? Because it's pretty bad. And then we got the mask issue. We've got all these different factors. They're just piling up, and it's getting to the point that nurses are leaving nursing. They feel like they're being abandoned by administration. They're looking for other jobs. They're being furloughed. They just feel like they're just left out there. Some nurses are just, they're going to do a different profession just because they just need a breather. Also, they want to, obviously they need to make an income, but sometimes people need a break. And how much can you ask from somebody? And we're going to weigh in with Dr. Jessica a little bit about how these stressors affect the genetics that we have, and how it translates to our future, right? So let's talk a little bit about this. So some of these slides might be a little bit old. So I'm located in Florida. Dr. Jessica is in Missouri. So we are actually in several different countries and around the world. We're in Australia, we're in UK, we're all over the place. Hi, Diva. Hi, Pat. I see you guys on there. I think Tanya just came on with us. So understanding the patient upon admission, the one thing that we are so transactional. We are so trying to keep going with our assignment, trying to keep, we're admitting the patient. We need more than two hands. Sometimes we bring our feet into it, we just don't have enough resources in order to be able to get our job done as it is. But when you're getting multiple admissions on one night, I had 5 patients, but I had 1 patient and I got 4 admissions. And that was rough. And that was on an observation unit. And I had to prepare some people for surgery. So I understand. So let's talk about what we know as nurses, but let's think about now, what is the patient going through? Okay. So let's flip this a little bit. So upon admission, they have situational anxiety. They don't know what's going on. This patient is coming in, they might be having chest pain, it might be a panic attack. Especially right now, there's a lot of anxiety going on. That's like one of the biggest mental health issues that we have as it is. And then on top of that with COVID, they might come in, they might be having panic attacks. They don't know, it's like the fear of the unknown. What is going to happen to me? It might be a single mom with 2 kids. That might be, we'll just say if there was daycare still enacting, in business, how are they going to get their kids? How are they going to do this? And then the bills on top of it, how are they going to make the bills? They don't have insurance. They can't qualify for insurance. They make too much money. Affordable Care Act is going to cost them so much money. We'll just say it's several factors. Okay. Fear of the unknown. We have established that. So then we have patients that have like undiagnosed or even diagnosed mental illness. Now we have this huge, thick, gigantic stigma where people are afraid to come forward and say, hey, you know what? I might need to get some help. Maybe this anxiety is a little too much for me. How about that? I had a traumatic brain injury like 20 years ago, and I'm afraid to go get accommodations, and I'm afraid to get help because I think I might not need it because I'm above that. How about when you have an undiagnosed mental illness where you have that anxiety? Everybody has anxiety, but it's how you handle it, right? And then you have the people that are on medications that still don't want to tell you that they have any issues and what they're experiencing. If they're seeing, having hallucinations, if they're withdrawing from any kind of drugs, because as soon as you say something, bam, stigma hits the wall. And then this person is feeling like, the nurse is over there like, hey, we got the addict over there on bed 5. I've heard patients complain about that and tears running down their face. I'm trying to quit. I'm here getting help and I'm getting, so the reason why we're talking about underreporting, but we're also going to talk about how the patient feels about when they come into the emergency room or when they're trying to get treatment. We have to figure out,
People already don't want to be under the microscope.
Right.
They don't want to report their own symptom profile. Even if it isn't intense, they don't want to tell us how they're feeling in general, and reach out for help because they're afraid of what that label might bring. They're afraid that they might get looked at or slapped with a stigmatizing label.
Right.
They might get looked at inappropriately because it happens all the time. Nobody wants to go and anxiety, which is the most common emotion that we feel. It's a protective emotion. We're supposed to feel it. It is what has actually led to our survival. But when it does go awry, that's a problem.
Right.
But nobody wants to talk about it because they are afraid that they're going to be labeled hypochondriac, overreacting, or any such thing.
Right. So, and thank you, Dr. Jessica, for weighing in on that. So these patients might come in off the street, so they might have been on medications while they were in the hospital, but then they got off of them either because of cost or shame, or because they didn't feel like they needed it. They didn't understand, they weren't educated properly, and maybe they might just go back either using more drugs, because we cannot control the person. And if they want to quit, then that's what they can do that. And we can help them. So in Florida, we have this thing called Baker Act. So this person comes in, they have to get evaluated to see if, medically evaluated to be cleared to be able to be admitted into like a mental health stabilization unit, or maybe get transferred to a detox or something like that. But this is an involuntary 72-hour hold. Like, this person cannot leave. They're there. Now, if they choose to be there, then it would be voluntary, but they just can't leave. They would have to be evaluated. And then they get a psych evaluation. So what do most nurses, like, what I have found is that nurses don't understand about CEWA, which is an alcohol withdrawal. There's also a CAGE assessment. They don't understand about withdrawals. And that is a part of our assessment. That is a part of, along with stroke assessment, it should be right up there with alcohol and drug withdrawal protocol, like assessment to see if somebody's withdrawing. So we need, I'm sorry, go ahead.
Talk about assessment for a second.
Yeah, sure.
So my number one, so I precepted hundreds of students. And I would have to say that the number one skills that I probably saw lacking was in notation from assessments. That was probably the skill set besides pharmacology was assessments. Being able to do a top head-to-toe assessment and document that appropriately, and then understand pharmacology. Those were the two skill sets that I probably saw suffer the most in school, and that I saw probably as the struggles in nursing school. And to me, that is doing a big disservice to our nursing patients. So in line with what, and I wanted to tie that in when they're doing that CEWA, because that's foundational when a patient is coming in, into being able to do that differential and being able to figure out what's going on and being able to understand that. I just wanted to tie that in because it goes back to what are we doing foundationally in our educational programs to enhance our students' understanding.
Exactly. And there's a big failure all the way with the Board of Nursing, and even with the credentialing centers. They give you a framework to go by. And if you have somebody that's has a completely different background, like we should be taking care of 100% of the patient. So mental health should be 50% and medical should be the other. Okay. And they even intertwine. Now, a lot of times when you have somebody that's not their specialty, or they were never taught adequately enough in mental health, and they become an educator, what do you think is going to happen? It's going to be the circle of crap. It's going to continue. And what's going to end up happening is that the patient is going to be the loser here, because when they're trying to, and this is even you as the provider or the nurse, or, the nursing student, because if you're not able to recognize these problems that can be happening, with like withdrawal, along with your regular health assessment, along with stroke assessment, if you cannot recognize this, you're going to be missing, and you're going to be wondering why that patient's getting violent with you. The patient's going to get, escalate, and they're going to, why don't we prevent that? Why don't we have that education to understand why it's important? And a lot of it has to do with CEWA, which is the alcohol withdrawal protocol. And there's also the opioid withdrawal protocol. And they should also be within the files of the Nurses Against Violence inside of the group. I'm pretty sure I put one in there. So if you're wondering what it is, I'll be happy to double check and make sure it's in there. And if it's not, I'll put it in there. We need to, as educators, we need to start talking about this because there's not a lot of opioid. We've had an opioid problem for a very long time. And it's been, you know, even in recent times since, like, we'll say 2008. Okay. We'll just say like that, because some of us were not nurses in 1970s. Okay. So when there has been a problem since, you know, that's expanded. So what do you think is happening right now? So alcohol sales are up. And, you know, people are using marijuana, which I understand it's legalized, but then it can lead to other things, right? We don't know. All we know is that we're here to take care of the patient. And that is our number one priority. By taking care of the patient, we're also taking care of and seeing that we need to be taking care of ourselves. And if we're not recognizing that, we always talk about caregiver fatigue. Well, that's not for the family. That's also for us as well. How are we eating? How are we coping with these deaths that we're having? How are we coping with, like, the stressors, everyone biting each other's heads off? How are we dealing with family life, right? Among all of this and thinking you're going to possibly bring something home. How are we taking care of ourselves? That should be the most biggest thing that we should be worried about. I'm trying to find the right word. We also have, like, people that are coming in that are homeless. So how often are you seeing them being discharged back to the streets, right? So, and that same thing goes with our people that are addicted. You know, they go either to an addiction center if they want to, if they want to withdraw from their substances. And sometimes they'll keep coming back and they'll keep coming back. And one day they're going to decide, this is the day that I'm going to officially stop. And we have to be there to say, welcome, right? So I want to talk about one of the most horrible assignments that I've ever seen, and I've seen actually worse. This nurse, my students could not understand why this nurse was so cranky. Why is this lady so cranky? She is throwing things, F this, F that, and she's just like on fire at her cart, right? Using her pill crusher really loud. I mean, she was upset, and rightly so, right? So how often do we get a nursing assignment that is completely outrageous? Like, we might have a nurse that has not even been on the floor or even been a nurse for a year that is a charge nurse. Now, don't get me wrong, we all got to learn somewhere, okay? I'm not downing the new charge nurse. Please don't take offense, because it's not meant to be that way. They come in after 3 days and they don't know what's on the floor. They get a report from the charge nurse, and it might be right, it might not be right, because depending on, you know, who's on the floor. Well, we do sometimes acuity, you know, the acuity, how severe the patient is assignment. But why isn't the mental health factored in there most of the time? It's not, right? So if you have somebody that's constantly seeking, and they're not really seeking to the point, they just need good, proper pain management, right? Mm-hmm. So if they're not getting proper pain management, they're going to be on their light all the time, right? And I know a lot of people out there are going to say, yep. They're going to be on their bell, and they're going to be screaming because they're going to see how far they can push you in order so they can get their pain medicine, or they're going to, because they need their next fix. Well, why did we not catch that with the opioid withdrawal protocol? Why did we not catch that so we can start them on some sort of withdrawal protocol? Right?
Because it is torture. It is actually physically painful. It is absolutely horrible to go through that experience. And it is inhumane to make someone go through that experience without actually medically treating appropriately.
Right. So it's very important that and we're supposed to do no harm, right? We took an oath. You remember that thing that we said at the end when we were holding our candles, and we were, you know, that's important. We need the Nightingale Pledge. Does anyone remember that? Yes, we all should remember that, right? So I want to talk to you about this assignment. It's been years ago, but we need to talk about this patient assignment. So this lady had roughly between 5 to 7 patients. It was a mixed acuity. The order of assessing and caring for patients has completely changed. So instead of us worrying about the person that had the heart attack or had chest pain, that's a diabetic, that needs, that just came out of surgery, those were our typical number ones that we need to look at. Well, it's kind of flipped. We need to be worrying about also the people that are withdrawing or possible withdrawing, right? Because they can become very, very volatile, and so can our other people. So preventing the problem before it gets worse. So we need to understand the patient and what is happening with the patient before we can never prejudge, right? Because we don't know how that patient is feeling and we are not them. So we have the order of assessing is completely turned upside down. So the escalation from patients 1 through 3 can occur with withdrawals or underlying mental illness. We have the nurse has 5 patients. It's a typical assessment. She has 2 patients. One's opioid dependent. Another one is homeless with schizoaffective, no medications. Patient number 3, cellulitis of the forearm, pending surgery to remove the needle. He had a history of heroin abuse, but he was saying he fell into a thorn bush because he's embarrassed. He doesn't want to tell anybody that, hey, I'm an addict. I fell asleep. The needle broke in my arm. He didn't want to tell anybody, but his arm is all nice and big and, cellulitis. He had to go to surgery. Patient number 4, status post 1 day, left hip surgery. So, and then we have patient number 5, rule out MI pending a stress test the next day. So he's on a monitor. He's kind of, good. So what would be the normal order? Right? The normal order would be, well, we have somebody that had an MI and we also have the hip surgery that's new. We have a guy that's going to surgery. So our priority is probably patient number 4 and then patient number 5, because that guy's on a monitor. We've already checked the strip and then we're going to go in there. If you could split yourself, then split yourself. That'd be fine. But then we have somebody going to surgery, and then we have the 2 patients over here where that one is addicted to opioids. So this is this nurse, this is her assignment. And then people didn't take the time, instead of saying, oh, that nurse is having an attitude problem. Well, did you ask? And this is what came out of my mouth. Did you ask to see if she needed any help? Did you offer? No, more times than not, people are so overwhelmed and they got their own assignment that they're not going to ask, hey, is there something that I could do to help you? Now, if you get Rizaldi out there, which is me, some people don't know my last name, I am out there and everyone's, hey, can I help you with this? Can I do this? I'm not everybody though. And I'm not saying everybody does, but we need to understand that there's more to the whole story and we need to be a little more proactive to prevent problems, right? So if I was this nurse, I would have never accepted this assignment. I would have asked them to split it up a little bit, because you're going to be going through, you have 1, 2, 3, and possibly 4 people that will probably be asking you for some sort of pain relief. Possibly, maybe, anticipate it. And then how often, and let's say about a year or so ago, I know that they're doing away with giving Dilaudid and stuff like they used to give out like candy. It used to be about every 2 hours. Well, if you figure you have 3 patients, or 4 patients, and you're giving them pain medicine for 12 hours every 2 to maybe 4 hours, how many times are you doing your charting before, when you give it, and well, you draw it up and then you give it, do all your rights and all that other stuff, of course. And then at the end, you have to reassess that pain. This is on top of the health assessment. This has everything, like if there's doctor's orders. This is just a lot of work, right? So if you're sitting at the nurse's station laughing and carrying on, you see somebody in the woods, how about you get up and ask and see if that nurse needs some help? Instead of saying
that actually would have happened. No, not when I was on the float pool. This would have been the normal assignment handed to the float nurse.
Right. But it also would happen to me. And I would be
so I was always given this assignment. And then I also, one of these would have been in isolation.
Oh yeah, you gotta love that. And then so we have this thing where we're not, if your assignment, and then if you have a patient that doesn't like the way you look, doesn't like this person in their room, there's nothing wrong with the nurse. There's something wrong with the person's perception. We talked about this in the last webinar. Doesn't matter what country they come from, what skin color they are, or their beliefs, if their sexuality or whatever, yet take over for them and give them one of your patients with the charge nurse's permission. There should be no problems with that. Some nurses will say, I'm going to take them anyway, and they're going to love me just the way I am. Well, that's fine. If you can get them to laugh and you can have, make it a lighter situation. But if it gets escalated and if it gets out of control, you could have avoided it, right? So sometimes you make that conscious decision about what we can do and what we can't do. And don't be embarrassed if you have to ask to see if you could switch somebody. Now, I know that's unrealistic with the way that things are going right now. I'm hearing that these assignments are astronomically hard and big. People that have not even worked in ICU are being trained just like that to take care of vents because, it's bad out there, right? So,
well, and that goes right back to some of what we were talking about in even just in the education status, and we were talking about, and it's not just nursing. We see it coming out, we see in the nursing programs, and we talked about, in BSN to DNP, and we see some of the dangers in that, and people not having the same curriculum. I've even heard in the medical schools, they're seeing the same thing. They're seeing, I've heard from physicians saying that they're seeing degradation in their educational programming, and they feel that the same is happening within their programming also. And they don't feel that it's capturing the same information within their students. And so they feel that there is still, that their students are coming out not prepared for what they're encountering in the real world.
Right.
They're not ready for it.
We have where I'm currently working until things, get lifted off with my psych NP career and stuff like that. I love where I'm working. I'm working over at Kaiser University. They're very, very proactive when it comes to teaching. We live in a pretty rough area when it comes to drugs and alcohol because we live right by the beach, and there's a lot of drugs and a lot of mental health over here. And we like to teach reality nursing, and we are very upfront. And I'm sure if Miss Alice is on here, she'll agree. We like to be in students. We need to help them understand it's not going to be pretty. So if you want to be nasty to me, we're trying to help and love you, because when you go out, it's going to be a free for all, and you will get eaten alive if you are not cool with your instructor, because they're just trying to help you understand what's happening out there. And if you do not know your stuff, there's going to be another nurse waiting off into the side trying to make you feel and belittle you. And that is incivility, that is harassment when they continue. And it just makes you feel like you're not ready to even be a nurse. It just eats away at your soul. It really does. And after a while, in many years, you might become nurse ratchet, who knows? But let's talk about influencing systems, right? So workplace violence, the policy, it focuses on potentially violent behavior and definition. It does not, like, when you look at a de-escalation program, it is starting from the middle. When you look at the definition, that's starting from when the person is already gotten escalated. That is like not preventing it, like keeping them pacified and, getting them something to eat, something to drink, something basic human needs, like we all need, like our breaks and stuff like that. They aren't getting the things that, they need. So if they're hungry, get them something, because some of the medications that people take, they might be hungrier than they normally would. Now, if they're a diabetic, you have to be careful. But anyway, most of the policies that you'll see are de-escalation. Now, their prevention program that I have trademarked is now underneath of Nurses Against Violence. We have it trademarked and patented and stuff like that, and all kinds of stamps on it. So it cannot be reproduced unless you have our permission. I have taken all of the different policies that are out there, with nursing agencies, nursing organizations, what they have with the government, and I've found holes and I have developed it. Now, you are not getting that right now. What I'm talking about is just like pointers. Okay. So what it does, it focuses mainly on de-escalation, then building the relationship with the patient, because we're so transactional, we are not able to take the time that we need with our patients. That is possibly a staffing problem, but there's a staffing problem could also be a culprit of bad behavior. So we have to understand, when you eat your young and eat your old and you're not nice after a while and you have administration pouncing on you, what's going to end up happening is that person's going to find another place quietly and leave because they don't want to deal with it anymore. So let's get back to influencing systems. We have violent behavior is alerted to the administrator on duty. Now, these are some things that I found, right? So the administrator that if something is happening on the floor, like we'll say a code gray is called, right? A code gray is called, and then the AOD comes and they see grandma throwing a milk, right? Code gray is a violent patient code. Well, they could prevent that code gray from happening with the granny throwing the milk by just being there and helping her through the situation, right? Not everyone's going to have a good day, but we can prevent things from happening. So a violent code should be something where there's patients actually punching nurses, and a lot of times these things are underreported. And let me talk to you why. Let me just explain why. The only time that a code is ever documented in a certain facility that I have been in and a couple other ones is when the administrator on duty actually fills out the report, right? Now, when the administrator on duty fills out the report, do you think the other nurses are going to fill out reports? Probably not, because they'll say, oh, what's your name? And what's your name? Okay, and then they put it on there, so they think that their report is done. Now, wonder if we have a patient that was punched in the face, a nurse that was punched in the face, and her jaw is broken, and then she goes to the nurse's station and says, hey, Sally, I can't barely talk, and I'm having a lot of pain. Well, that's a whole nother scenario I'll get to another time, where she is victimized at least 10 other times outside of the charge nurse rolling her eyes and making a big deal about it. And then the nurse is being left without a nurse, right? So what ends up happening is that those nurses get angry at the nurse for leaving because of the fact that they have to take on this violent patient. On top of that, all these other patients that they don't want because they're busy. They do want them, but they're busy. So, and it's very hard to keep up with what they have already. So when they do that code gray report, that administrator on duty fills it out, and then everybody thinks that everything is fine and dandy. No, it's not. So the data is pulled out by only the violent code situation, and then the AOD or the nurse manager, no data is collected or preserved. Why do we not believe? So when we go to the nurse manager or we go to the charge nurse and the charge nurse goes to the nurse manager, do you think the charge nurse is going to fill out a report? Answer honestly. Anyone? Okay. So we have people watching. Thank you very much for watching. But more than likely, what do you think, Dr. Jessica?
Not usually.
Right, because they want to squash the problem before administration finds out, because the more reports that they have, it looks like they're not handling their floor correctly, which I look at all sides. I'm a devil's advocate, right? So they don't want to be pounced on. They want to look like they're doing a good job, and they really are trying. Okay, I'm going to give them the benefit of the doubt. I'm being very nice, okay? But by not reporting the problem, they don't have the resources that are going to that area, and they don't have the information to be able to make sure that the staff is safe, right? So, and if they did, would they do something about it? Probably, and probably not.
Most likely not. When I used to report problems, that's actually why in administration, the only position I got terminated from was because ultimately they did not like when I reported events, because they said that they wanted things handled internally and didn't want official grievances by patients filed. They were upset by that because it was those were reported to Joint Commission. They didn't want those on file. So they didn't like that I filed them. Management told me to keep them silent. I did not agree. So I was basically, I wasn't fired. I was told I could resign or I would be fired.
So basically, either you do it the nice way or we're just going to make you.
Yes.
Yeah. Yeah, I understand that. So the biggest thing here is, of course, the safety of our patients and the safety for other staff. We don't want anything to happen to anybody, because we became nurses because let's just use this thing where we all actually love each other and we care about each other. We should, because we are family. Nurses and healthcare workers are all families. And when we're great, we're awesome. When we're bad, we're not so good. And the whole part of Nurses Against Violence is to stop that violence and to bring everybody to start to come together. Okay. So let's take this even farther. So again, a safety concern, preventing behavior escalation, and educate nurses about reporting. So when you ask a nurse, hey, did you report that? Did you report that? Did you report that? Hey, no, nothing's going to happen anyway. It's just a part of the job. You know, I say things and all I do is I get treated like I just shut up and just put my head down and keep going, because it's just going to make me miserable. I've heard it all, right? I've even thought it all, right? Because there's been a lot of places that there's probably been one or two places that I've absolutely loved to work at. And one of them is where I'm working right now, and I love them. So, and it's very important to empower each other with this information, both, you know, about the tools that you have, about helping your coworkers with assessment, as well as also with spreading the word about how important it is to report. Because if there's no written reports, then nothing can be done. Let me take this a little bit further. So creating a culture of reporting is very important. So this was my first reporting box. So this is what was my ticket out of my DMP project. It was, the project that I had was anonymous. It was simple. It was non-persecutory. And it was like a few questions: night or day shift. Did you get kicked? Did you get slapped? Did you get punched? What happened? And there's no names. You could report it for me, Jessica, because I might be too scared. We just needed numbers. Just by doing this, in 1 week, we had one report. The second week, we had a 900% increase. Now, that told me what's going to happen next. Okay. So yes, this did not look like the most pretty setup, but let me tell you, we were about to expand this throughout the whole hospital system. And the day before we were going to do it, I was shut down. So they didn't like what we were doing. And I wasn't doing it to be, I wanted to make a job for myself. I wanted to make a title for myself. I wanted to do good. I wanted to change everything. Instead, it just made me work harder and made me really, that's why Nurses Against Violence is here. Because I wanted to change how things are and how things are going. So, so it was anonymous and it was using a teamwork. So everybody can report, hold educational forum about reporting barriers, which, you know, we talk about that all the time. Fear of retaliation from the employer, that is rampant. No light duty. If you're injured, you must go out. Workers' compensation pays approximately 60% of wages. So if you're a single parent, you can't afford, even if you are like married, sometimes more times than not, you're not going to be able to afford only getting 60% of your wages. On top of that, you have to use your own personal time that you accumulated and that organization gave you, just to say, here you go, you deserve this. Here's your vacation time. That's why you're seeing a lot of PTO time turning into just plain sick time, because they're not going to do that, right? You're not going to get a vacation. You know, I would hope that they would still keep it separate, but I'm seeing it more and more going in combination. Again, we're going to talk about, it's a part of the job. Not reporting the verbal or physical violence conditions that patient, so the patient does more. They get more escalated. Like if something happened to me on the floor and I don't say nothing, when Jessica comes in after me and I give her report, Mr. Smith gets even louder. I doubt it because she's awesome. But like, do you understand where I'm saying is that if they didn't get their way with me, they're going to get their way with Jessica. Right. So we have to report these things so we can make a safer environment for everybody. So, and if you say something, more times than not, nurses are viewed as being substandard. They're not qualified. They're not competent to be able to take on their position because they can't handle X amount of people. I tell you one thing, when I worked on the floor, I asked for the difficult people because I like difficult people because they're my people. Like I understand them, right? All they need to do is do this, and you need to do, what is it? You need to do more of this and less of that. And then people are going to really, even if you're just standing there, they're, I don't, borderline, whatever. I hear it all, right? I hear all of the complaints from healthcare staff. Love everybody just the same, because I'm going to tell you one day it's going to be you in that bed, and then you don't want to be dismissed, right? So
9 times out of 10, that borderline diagnosis is wrong.
Right. And we were talking about that just the other day, right? We were talking about how you were saying that Asperger's is almost exactly like borderline, just minus the manipulation. Mm-hmm. So, a lot of stuff when Dr. Jessica talks, she has a lot, she does a lot with the brain, right? She's like the next Stephen Stahl, but in female form, in nursing form. So the benefit of reporting helps everybody, right? So why it's not that you're being a snitch. It's not that you're, you have to report, otherwise the numbers are not going to be there. So when I took this a step farther, right, when I was let go or whatever, right before, they didn't realize what I found out. So when you look on the reporting screen, right, there's different boxes. Nothing about workplace violence. There's a miscellaneous box that says provision of care. I even took a screenshot of it because I thought it was funny, because like, it's not funny, but it's funny. How do you have a box called provision of care? So you're already labeling it like the nurses are doing something wrong, right? So everything that goes in there, and you have like a 10 to 15 minute report that you have to fill out. Now, I wonder if you were injured. Now, if you got injured and that you wanted to press charges, you had to do it on your own time. Why is it that you have to do it on your own time, right? And then when you report those reports, where do they go to in that miscellaneous file? Nowhere where the official organizations need to see them. They go out the trash. So therefore, when you fill out the report, nothing does happen. It just disappears into miscellaneous oblivion, huh?
Circular file. They don't want it seen.
No. So the outcomes. So nurses have adapted to the future of, to the culture of reporting workplace violence. That's what we want. We want every nurse to feel comfortable about reporting, whether it be anonymous, whether it be, forthcoming, whichever way. We are working with Nurses Against Violence has, copywritten, has their own, we have our own reporting system. It's going to be called the Rizaldi Anonymous Enhanced Reporting System, AKA REARS, a shot to the rear, because it is vital that you should feel comfortable about reporting it. And we would be the ones, not Nurses Against Violence is teaming up with Together Wellness, and they're going to make sure that that report gets going where it needs to go. And if there has not been a response, then we're going to follow up and make sure that that response is made, right? So that way, whenever you have something that's pressing, whether you need to report it to the Board of Nursing, you need to report it to the OSHA, you need to report it to even administration. Maybe we can work with hospital systems. I would love to do that to help them to be more compliant. I would love that. And then we have the police department. We can talk about how we can report to like literally all reporting agencies that have to do with curriculum, all of that. Like that's what we are working on. So we are going to be the leaders of healthcare, period. Acuity to staffing protocols shift to accommodate the patient load. So we need mental health and we need medical to blend with this acuity staffing. Now I understand that, oh, it's so difficult. No, it's only difficult until you start doing it, and then it's hard, and then you work on it, and then it becomes easy, right? It's just getting everybody used to, oh, mental health's everywhere, because everybody thinks it's only on one floor. It's not on one floor. You have people that have schizophrenia having babies. You have people that are, that have mental health challenges or addiction that broke a hip. You have all kinds of different departments that have mental health patients. So it's very narrow-minded to think that people that have mental health and addiction issues are just on a mental health floor and just come into the ER and then they just want to seek. No, we need to take care of them from beginning to end, regardless. You were going to say something, Dr. Jessica.
No, I just got one again.
Okay. So if we, what is the end result of not having this reporting mechanism? If we do not stand up and start reporting these things are egregious, if we do not report it, then we are already seeing burnout. We're already seeing post-traumatic stress disorder. It is not compassion fatigue. Compassion fatigue is a fluffy little pretty name on a horrible thing that's been like forever out there. And then let's talk about learned helplessness. Well, y'all are a part of learned helplessness with the masks and, and having to rewear them. And they're trying to mold you into something that they want you to be in this nice little tidy box. Okay. So you are not able to speak your mind, to be able to do the things that you need to do to make sure your patients are safe and you're safe. Okay. Learned helplessness is happening right now. So I don't want to hear anything about moral injury. Moral injury is learned helplessness. I've been talking about this for years, as well as also compassion fatigue is just a pretty little name. It's really burnout and post-traumatic stress. It's everywhere. Everywhere. So, and then when you have this, at least the turnover, at least the poor scores, organizations need to get it together. I would love to be able to work with them. I'm not against organizations. I just want to make sure that everybody is being addressed the way that they need to be and taken care of, right? Not just the patients. It's about if you have happy nurses, you have happy patients.
They don't want to call it PTSD. PTSD means they'd have to pay workers' comp.
And there's a lot of things that workman's compensation does not pay. So, and one of them is not, I just found out something about anxiety is not on that list. So, and PTSD is not, and we have somebody that's with our organization that has also had to fight workman's compensation for PTSD because they saw a patient hurt themselves in front of them, right? So, needless to say, we start taking care of the real problems, then patient satisfaction scores are going to go up. Do you think that guy, that patient assignment, that right here, who do you think is going to do the most complaining about their care? It would be the person with the hip and the stress test, because they're too busy over here trying to take care of these people and getting their pain medications because the acuity was not taken care of the way it should have been. Right. And yes, you can have people go in there and say, hey, how you doing, Mr. Smith over here? How you doing? That's fine. But this patient walking the hallways, they are seeing you busy, but you're going to have more complaints out of these guys than you are about these guys because you already know what the complaint's going to be about. Right. So anticipate things and then your shift will go a lot better. So job satisfaction scores go up and you have nurse retention. When you start taking care of these needs and start reporting things and things start actually working in the favor of nursing staff, nurses are going to be much happier and they're going to want to be there. Right now, it is not conducive to nursing care and the nurses that are taking care of the patients or the CNAs because they're right there on the front line. Our doctors are working hard, nurses aides, are the people that are cleaning the rooms, which I'm finding out now is more nurses than it is housekeeping because of the rise of COVID. We need to take care of ourselves. If you have a nurse friend or you see a nurse struggling, please step in. Please try to be the friend to them because I'm going to tell you, we're going to have a lot of new nurses that are coming out in the field that are having a lot of simulation. Please take them under your wing, mentor them, They're having simulation because they can't go out the clinical. Okay. It's very important that everybody please take care of the new nurses that are coming out, because we need them. We all need them. You complain about staffing, you complain about everything, but please take care of the new nurses, because they're going to be what's going to take care of us when we get older. Right. So, and then I got my little references and stuff like that. So what I want to do is let Dr. Jessica talk a little bit. I would like her, if she would not mind, to talk a little bit about what all these stressors and all these negative things, what happens, because I know we're trying to keep the webinar short as we can, about what happens to you as a person when you're taking on all of these traumatic things that are happening. You're trying to keep up. You're probably going to school still, juggling a family. You're dealing with whatever's happening at work. You're getting furloughed. What is happening to the person? So, and I'll let you go ahead and talk. So thank you.
Call it not rocket science.
Yeah.
There is fancy terms for it. And that is the science of epigenetics. And what starts to happen. And usually it's not pretty. So I always say trauma and stress, we've talked about it for a long time, that turns on our genes. Usually, to me, it's always presented in a more negative direction. When we talk about resilience, in my opinion, for patients, we have genes, to me, that are more protective, that keep people more stable for longer. But over time, everyone's going to crack. It's just a matter of when and how long. And what are going to be the symptoms that you present with, and our genes encode for that. And epigenetics is kind of the study of that. So when I have patients come in and I read like the gene profiles that I have now, and they look at me and they're like, oh my gosh, are you Nostradamus, or what, are you some kind of mind reader? I'm like, no, I'm just looking at your genes. Because how we react under stress is highly related to genetics, especially when it comes to there's certain genes that play more of a role, and some of them are more dominant than others. Sorry, I try and escape to rooms.
You're fine.
There's one in the background. I know, isn't that funny? My God, that's my middle one. But so these genes that are more dominant can present themselves, and when I have patients, I'll be able to kind of tell them, okay, this one encodes for maybe more obsessive ruminating anxiety. So if you're stressed out, you may be more likely to ruminate, get obsessive, start getting in your head. You might start to avoid conflict. And I have people that will say that, oh my gosh, I get sensory overloaded. I can't deal with it. I start to have to go in the corner and I have to go hide, and I just can't deal with all the lights and the sound. And I just start like thinking all the bad things, and I just can't, I replay things over and over and over and over in my head. And I have to avoid things. And then I want to sleep for 6 hours. And then I don't want to hang out with anybody. I don't want to be around anybody. Some of these people say they start repeating behaviors more. And it happens. The more stressed out they get, the worse the behaviors get, the more it starts to happen. And it's interesting because these patients, these avoiders in a fight, it'll be the same thing. So this is that person that tends to be more passive in an argument. So when that nurse manager is coming at them, this is the person that deflects. They won't say anything, and they tend to back down, and they tend to be very shy in the fight. And so they'll probably quit. They'll probably quit that job. Or they will burn out really fast, or they won't say anything. They'll beat themselves up. They'll go home and cut themselves. They'll go home and commit suicide.
Yep.
I see a lot of that. Or you'll have that patient. I have the ones with a different mutation. They have the quick to temper gene, as I like to call it. And there's only so much they can take. This one looks like they get angry at small things. I have one in my family or two, and they get mad at video games, and they will throw a remote control when they get angry at the floor and break it. And we have to work on that behaviorally. The more stressed out they are, the more frequent it happens. And so we've had to work on how to not get dysregulated with their emotions so that when they're playing a video game that's stressful.
I think you're talking about something that's very close and dear.
Those things are $40 each.
Well, actually, they're more. The PlayStation ones are about.
If you're buying the knockoff ones, they're $40. So when you have to go through a few of them, you start to look for the knockoff ones. So yeah,
Sorry.
it's okay. So yes, there's, and the more stressed out, the more frequent these behaviors can happen. Or there's other ones that cause more self-esteem dysregulation. And I also like to say, ones that may cause difficulty with reading your surrounding environment. For people that have their difficulty reading surrounding environment, the more stressed out they become, the more errors they make in reading their environment. So we actually lean toward the difficulties that our genetics may cause. The worse the stress is, the worse the trauma that becomes, the more pronounced, it's like pouring gas on the fire. So the more pronounced these traits start to present. So then it becomes clinical. So everybody's at risk. When people start to say, mental illness, it's not going to happen to me. Yes, it could. Mm-hmm. I could look at your genes and probably tell you what you're at risk for, at least personality wise, not necessarily say it's going to be this, but I could say what kind of symptom type things you might have, whether you might ruminate, or whether you might become obsessive, or whether you might become headstrong or stubborn, or might dig your heels in too hard, or might start to have all the kinds of moods.
So the epigenetics, mm-hmm. it changes your DNA.
It does not change the actual coding. So it doesn't actually change the letters per se, but it changes the presentation of it. So this is the way it presents, kind of your phenotypical presentation. So we can have genes changed, like say a virus came in and knocked out some genes and changed that. That does happen, but that's not necessarily what epigenetics is studying as much as the way our presentation changes from the wiring over time. Our DNA can actually change for different reasons, but epigenetics more so studies the actual presentational changes from chronic stress. And what they are actually finding now is that the chronic stress over time, actually, even those tags, those markers that get left, is even passed on. So what they're starting to find is that they believe that some of those changes, some of that wiring that happens based on how we're presenting, may influence, because if it's telling certain like if a gene may encode, if some, like under stress, if certain hormones may turn a certain gene and tell it to start then producing more of one thing or another, if it's influencing then our offspring genes to do something, it's going to be passed on in our offspring genes. And so we are going to see that. And so they can actually, now they're starting to look at how over time is there maybe changes and shifts in the offspring of people. And they've even found like people during times of famine, especially with like eating habits, they've found during periods of famine and stress, people that have had different food scarcity. It actually affects obesity and birth weight on their offspring. So they're marking more of those changes as well to kind of follow that.
So you mentioned also, sorry, you mentioned also about like, so you mentioned cutting, people go and they do self-harm at home, they drink and they, you know, maybe self-medicate through somehow, because they're too, you know, and I'm finding too, working in, you know, mental health for so long and working on in med surg and even tele, and even with students that we, sometimes believe that we're invincible, like we, you know, that it's a, you know, that it's just for everybody else, it's not for us, we're good, we have this metal armor, and we don't, we suffer just like everybody else, right? So, and then it, how, as you were saying, it changes.
Mm-hmm. Well, first there's the I can take care of it, I can manage it
Mm-hmm.
because I'm in healthcare. Second, there's the fear because I know and it's interesting because at least in my area, there was always this fear in Missouri, at least, because that's where I've been the longest. Nurses didn't come forward about substance use disorder because they were afraid of losing their licenses. Mm-hmm. So in Missouri, physicians, they were given all the opportunity for help for substance use disorder. But if you came forward as a nurse, you lost your license and you were done. Like that's it. So no nurses ever come forward to get help. They could not. They were completely stigmatized and shamed because there's not the same assistance that physicians received from their boards. Is how I was always reported from anybody that had ever gone through substance use in the past when I was treating individuals who had recovered. They said that they actually had to hide it when they went to go seek treatment and stuff. They couldn't ever come forward, and they had to do it in silence, and it took that much longer for them to get better. And I see that also in just basic mental health, not just substance use, because there's that fear of someone knowing them, of someone finding out who they are. I feel like in nursing, they feel like it's a smaller community. I mean, I saw it in the physicians too. A lot of physicians didn't want to come forward because they were afraid someone would know them also and a patient would know them. But I did feel that the nurses went through the same thing. They didn't want to come get treatment because they were afraid that a colleague might find out their full story. And so they didn't seek care.
And that's one thing that we're gonna we are actually working towards, is to have like eventually a third party type of insurance program with Nurses Against Violence Unite to help nurses to get on their feet and healthcare workers to get on their feet from having their employers, you know, their insurance stuff, to find out what any conditions that they, it's all provide, they're supposed to be protected by HIPAA, but we know that things get around, and we would like to think that that doesn't happen, but it does. But just so the safe, so the healthcare worker could feel more like they can get things done with their mental health care and whatever healthcare that they need. That is why we're trying to step to the plate to make sure that this is going to happen. So to be able to provide care for our healthcare population, so employers don't have to be in their healthcare. That way more people can come forward with their mental health and addiction issues, and they don't have to feel ashamed that they have other nurses that are that, you know, understand. And, you know, there's nurses that we're going to have that have been through addiction, that have been having some sort of mental health challenge. And we are also going to have regular providers to help also with like colds and the sniffles and all the other stuff. So we're going to have all that care for you, and that's going to be coming also through Together Wellness. We're going to be uniting with them because it's extremely important that we take care of each other. Mm-hmm. So with that being said, I want to thank everybody for coming on to Nurses Against Violence Unite and joining us with the group. And please bring your friends, family, to give you that extra support to see that you're not, that is, there are things that are happening in healthcare and that you are not crazy. That's, we have a lot of families on here that are just like, you were right, you know, this is happening and I'm so sorry, this, I feel terrible. But it isn't about just making your family feel terrible. It's about having them understand now that what you've been saying all along is actually a problem. And the more support that we can get to lift us up, the better, and help lift each other up. And that is vital. So we are Nurses Against Violence Unite, and we have a few people that were not on tonight, but we're going to have a bigger event next week. We just wanted to keep this intimate, and we want to thank you very much again for taking your time out this evening to watch us. And hopefully you got some information that might be useful. And let's get out there and change healthcare. Okay, guys?
Bring us your voices. Bring
Yes.
us help, please.
Yes, absolutely. All right. Bye, guys. Take care of each other.